Please.
Thank you, dear Chairman. Dear colleagues, thank you for coming in such a sunny Sunday. So in this 30 minutes, I'll go over the hypervascular lesions and how we can approach these lesions in the clinical practice. And these are the learning objectives. So we're going to go over the typical and atypical findings in the benign lesions. And I will show you how we can differentiate between benign and malignant lesions. And we'll show the roles of CT, MR, and ultrasound. So this is the outline. So first, I'll go over the definition. What do we call hypervascular lesion? And the location is extremely important. Liver is a really interesting organ. So if you see some pathologies at certain locations, it's a very important clue. I'll go over the hemangioma. Actually, 50% of my talk is hemangioma because it is the most common lesion, the typical and atypical forms. And I'll talk about hemangioendothelioma. This is an interesting lesion. Once you know the imaging findings, you would be able to diagnose this lesion. And also, fatty liver is important because there can be fatty lesions or there can be diffuse fatty liver, so this can cause diagnostic problems. And most of my talk will be regarding normal patients. So normal patient means no cancer history, no hepatitis history, no cirrhosis history. And also, I will talk how we can approach the lesions in cirrhotic livers and cancer patients. Briefly talk on the help of diffusion and PET-CT, and we'll go over the problem solving. And I'm planning to show you 20 cases regarding the hypervascular lesions. So what are the vascular phases? I was lucky because in my early career, I was able to work with Dr. Foley, and he wrote this seminal paper in AJR in 2000. And he showed that there can be certain different phases in the liver. The first phase was early arterial phase. This is the phase where we see the hepatic artery, and this is approximately 20 seconds after the contrast injection. The next phase is the late arterial phase. This time we see the hepatic artery and the portal vein, but there's no contrast in the hepatic veins. So this is approximately 30 to 40 seconds after the injection. And next phase is the venous phase. Now we see the portal vein, hepatic artery, and the hepatic vein. And this is approximately 60 to 70 seconds after the injection. And also we have an equilibrium phase. This starts after 120 seconds. So this is the imaging that we get from the dynamic imaging of the liver, either with CT or MR. But the important thing is now we're moving a little bit towards the late arterial phase. And the reason is we see hypervascular lesions on this late arterial phase in a better, we have a better visualization of these lesions. And this is our protocol in our hospital. So we obtain a late arterial phase. You can do this if you're using a bolus tracking. If you had 10-second delay or 15-second delay, you would be able to catch the late arterial phase. And then we acquire a venous phase. This is 60 to 70 seconds. And an equilibrium phase, and your slice thickness it's a good approach to have it less than 3 millimeters. So are these lesions hypervascular? It is really hard to call on a venous phase, but once you have an arterial phase, you can tell these lesions are hypervascular. And this can allow you to put a differential diagnosis. This is a neuroendocrine tumor metastasis. So once you see the hypervascularity, it can help you to diagnose these lesions. There are many hypervascular lesions, and the third speaker, Professor Felipe, will be talking about the focal nodular hyperplasia and hepatic adenoma, so I will talk about the rest. And I'm pushing this thing in the liver imaging, this biopsy-less diagnosis. I mean, you're able to diagnose a lot of lesions in the liver without biopsy, and you have to be aware of these. We have very strong diagnostic tools to do this. How about this patient? This patient was a pediatric patient. Does anyone think this CT is abnormal on the venous phase? It looked normal to us, but once you acquire the arterial phase, you can diagnose this rare lesion. It is called Oster-Weber endo disease. Most of the time, the clinical question is there a liver involvement? Because this is important from the prognostic point of view, and you can see the difference. The venous phase is normal, but arterial phase is diagnostic. How about this one? This shows you, again, the importance of the vascularity. This is a nice hemangioma, but look at this lesion. If you see it on a venous phase, you would call it a tiny sub-centimeter lesion, but if you look at the arterial phase, you see the FNH. So this is invisible on the venous phase, and it is definitely visible on the arterial phase. How about the location? As I've told you, location is extremely important for liver imaging. Why? Because we have another inflow apart from the portal vein and the hepatic artery. And you have to be very careful if you're calling a lesion in the segment 4 and at the posterior aspect of the segment 2 and 3. Also be very careful if you're calling a lesion in the subcapsular area. And also periportal area is very important. So I'm going to show you some images. First, when I saw these kind of lesions, I was kind of puzzled because I didn't know what to call them. And you can see that most of them are in the segment 4, and you see different things. But just look at the subcutaneous fat. You see some vascular structures. This is due to the occlusion of the either inferior vena cava or superior vena cava, and you have a retrograde flow into the liver, and this is called third inflow. Okay, what is the reason for this? I call this Matsui phenomenon because he has over 400 articles, and he published the seminal papers on this issue. He is a very prominent liver radiologist. So the first one is the segment 4 anterior part. You can see it here. This is due to a subpay vein drainage. The second one is the segment 4 posterior part. This is due to usually aberrant right gastric vein. And segment 2 and 3 posterior part. So let's see these veins. Can we see them? Definitely we can see it. You can see that this is the subpay vein. This is the aberrant right gastric vein, and you can see it right there because there is a focal fatty sparing. And look at this patient. Actually, this patient, you see the aberrant left gastric vein entering the liver on an arterial phase image. And look at this one. There is sparing in this area, and this is what we call aberrant left gastric vein. So if you look at the images carefully, you can diagnose these entities. And most of the time, you either have focal sparing at these levels or focal fat. So these areas behave differently than the rest of the liver. Okay. How about the subcapsular area? Don't call these kind of things the lesions. Again, the clue is the subcutaneous fat. Look at the vascular structures. These are all subcapsular veins, which we don't see normally. And this is another interesting case. You can see the perfusion hypervascularity, and this equals out on the venous phase. So this is the clue to the diagnosis. And just remember, subcapsular areas can have pseudo lesions. Okay, this was one of the very interesting cases that we have ever seen in our practice. Does anyone have a diagnosis in this patient? Because we were puzzled. One of our professors saw the lesion, Professor Özmen. He thought that this could be intravascular leiomyomatosis, and we agreed with it. But when we biopsied this was a pancreatic neuroendocrine tumor kind of filling all the portal vein branches. And I'm going to show you the axial images. You see it. The portal vein is totally occluded with the tumor, and it is really difficult to understand this on a venous phase image. So look at this companion case. This case came 4 months later after the first case, and now this was an outside study. Look at the arterial phase. Early arterial, late arterial, again a tumor filling the portal vein, and on the venous phase you see the washout. This was another pancreatic neuroendocrine tumor kind of completely filling the portal venous system. So if you see anything like this, just look at the pancreas. Okay, how about this one? Does anyone have a diagnosis? There are 4 sub-centimeter lesions in the liver. If you haven't seen this, it is really difficult to diagnose, okay? Now I'm going to show you some MIP images because these are all aneurysms of the hepatic artery. So look at the distribution. They're periportal in distribution, and this is extremely diagnostic of this condition, which is polyarteritis nodosa. Okay, how about this one? My friend Giuseppe Brancatelli, he likes showing these images because this is a perihepatic lesion actually. But look at the enhancement. It is a hypervascular, but the spleen looks funny. And when we did the MR in this patient, there is diffusion restriction of this lesion because this is a normal spleen which moved next to so this is splenosis, ectopic spleen next to the liver. Usually we see these in patients with trauma history. And normal spleen has a restricted diffusion. Just be aware of this. Another patient, a difficult one. This turned out to be, again, ectopic spleen or splenosis next to the liver. Now we come to hemangioma. It is the most common lesion. So this is the most common lesion you're going to be seeing in your clinical practice. So briefly, I'll go over the pathology, ultrasound, CT, and MRI findings, atypical forms, associated lesions, and complications. And Dr. Casairo Alves has an excellent article in European Radiology about this issue. So we have two different kinds of hemangioma in the liver. First one is the cavernous hemangioma, and the second one is a capillary hemangioma. Usually the capillary hemangiomas are less than 1 centimeter. And some people think that this is the last step. Solitary fibrous nodule is the last step of hemangioma, and I'm going to show you some images supporting this concept. So I always like to show this image to gastroenterologists because they're always puzzled, because whenever they see a hyperechogenic lesion, they call it a hemangioma. So how many people think that lesion 1 is hemangioma? Okay, 2. Okay, let's go to CT. The small one is a lipoma. The other one is a hemangioma. So hyperechogenicity is not specific for hemangioma, and I can tell you that almost all hypervascular lesions can be hyperechogenic. So you have to be aware of this issue. Okay, so this is the typical hyperechogenic. You see the posterior enhancement. This is also fairly typical, hyperechogenic rim around the lesion, but this might be a little bit difficult because as the hemangiomas get bigger, they become heterogeneous. So biggest difference between CT and MR is the better contrast resolution. And this is my name, and you can see the code in my name, actually. It is called MR. So now we'll shift to the MR, and I'm going to show you some very interesting cases. And this is a very interesting article which appeared in Nature. So I want to show you some statistics, okay? So the blue bars represent the MR studies per 1,000 people, and the yellow one is the CT. Look who's leading the war. Of course, Greece is leading the CT. Look at the US, they're leading the MR, but we have a tie between Greece. Turkey is the second country who does many MRI examinations. But look at the CT. We do almost half of, so we do less CT to our patients than MR examinations. The reason is it's so cheap in Turkey. It's 25 euro per body part. In Europe, it's around 100 to 200 euro, and in US, the approximate value is $600. So it's, if you need an MRI, come to Turkey, you can have it for 25 euro. Also, we're moving in the touristic place. So this is another interesting statistic. You can see we're following Italy. So there were like 34 million tourists last year coming to Turkey. So I would like to invite you also to this beautiful country. Okay, how do we see the hemangioma? This is fairly typical. Once you know it, you're able to diagnose it. Arterial phase, peripheral nodular, this continues. This is extremely important. And centripetal enhancement. So we have contrast enhancement coming from the periphery. What is the reason for this? We are looking at the simple perfusion data because the blood to the hemangioma is coming from the periphery and it goes to the center. Can we have an additional value from MR imaging? Yes. In addition to the vascular diagnostic information, it is very bright on T2 weighted images. So this can help us in difficult cases. How about this patient? This is typical hemangioma, peripheral nodular enhancement, and you can see flash-filling hemangioma. So flash-filling hemangiomas are different than the cavernous hemangioma. You can see enhancement, diffuse enhancement, and they keep the contrast on the venous face. So this is also fairly typical for these kinds of hemangiomas. Okay, now I'm going to go over the life cycle of hemangioma. In the pediatric patients, we usually see circular enhancement, not nodular enhancement. But in the adult population, we see discontinuous nodular. But once hemangioma starts dying, you see a combination of the pediatric and adult form, which is circular and nodular. And in all kinds of hemangioma, you have centripetal enhancement. Okay, let's see. So this is a baby hemangioma, circular enhancement, and the contrast goes to the center. And this is adult form, and you can see the nodular and centripetal enhancement. So this is the baby hemangioma. You can see the circular enhancement on the arterial face and complete filling of the lesion. And look at the T2 signal. So this is very helpful. And you can see that these are 6-month intervals. You can see after treatment in a pediatric patient, hemangiomas can get smaller. How about diffusion in benign hypervascular lesions? It is not extremely helpful, but it can help you to rule out pseudo lesions like fat sparing, as shown by our moderator in a radiology article. And if you want to have more information, you can look at the Dr. Villigrain's and Towley's and Dr. Muko's articles to have more information. But just remember that benign lesions can also have some form of restriction. So this is extremely important. And hemangiomas, we see T2 shine-through effect, which means you see it bright on T2, bright on diffusion, and bright on ADC. So this can be helpful for diagnosis. Okay, atypical findings. I will be focusing on the sclerotic hemangiomas. I will show you a hemangioma with a scar and a capsular retraction. So actually, the most atypical thing would be if you're using EOB DTPA for diagnosing hemangioma, you can get puzzled because you have background enhancement of the liver. And look at this hemangioma. It is filling, and it is almost has same signal intensity with the liver on the venous and equilibrium phase. And look at the hepatobiliary phase. It is dark. So, and also I'm going to show you two more hemangiomas. You can see them darker than the rest of the liver because this contrast agent is taken up by the liver cells, and you might see hypo-intense hemangiomas on the equilibrium and the hepatobiliary phase images. And this sign is very helpful if you're using MR for diagnosis, because on CT these are very difficult to diagnose. If you see the sign described by Dr. Choi from Korea in the early 90s, you can see the very vascular area. Usually it doesn't fill, but it's very bright on T2. So this can help you to diagnose atypical forms of hepatic hemangioma. And this is another hemangioma. You can see the scar. It's a bizarre lesion. It fills the whole right lobe. And you can see that the enhancement pattern is very diagnostic. So once you see it, you would be able to diagnose it. But this lesion, we were not able to put the preoperative diagnosis. This patient had a retraction, which is not a good sign if you're doing liver imaging. You can see the retraction. The T2 signal is not very high. You can compare it to the gallbladder. And look at the enhancement pattern. We were kind of puzzled. We sent the patient to surgery. It turned out to be a sclerotic hemangioma. And you can see the T2 signal. The reason for the T2 signal is there is increasing fibrosis, fibrotic tissue within the hemangioma. Okay, we learned from the other case, and we used in this patient. So we saw 3 typical hemangiomas. But look at this lesion. This is a dying hemangioma because the enhancement pattern is almost circular. You see some nodularity, and you see the centripetal filling. So we were not sure if this was an hemangioma, but there were other typical hemangiomas in this patient. We put the patient on follow-up. We've been following for 2 years, no increase in size. So this is very typical for these kind of lesions. And there can be associated lesions in patients with hemangioma, and the most common lesion is FNH, as shown by Dr. Wilgrain and Brancatelli and Dr. Menu. You can see that FNH is the most common lesions in patients with hemangioma, and this is a very nice example. On the same slice, you see an FNH and a hemangioma, because this takes up the contrast, so it's very easy to diagnose FNH, which will be further elaborated by Dr. Felipe Casaro-Alves. How about the complications? Complications are extremely rare in this lesion, and one of the most common one is Kasabach-Merritt syndrome, which is called consumption coagulopathy. But just remember, sometimes it is a very difficult diagnosis on CT. Look at this patient with a lung cancer. It is not possible to diagnose this lesion in hemangioma, but once you do the MR, due to better contrast resolution, you can see the peripheral nodular filling and T2 high signal. What you need to do is don't biopsy these lesions, just put the patient on follow-up and just show the stability of the lesion. So this is the bottom line for these kind of lesions. But in certain patient group, like patients with neuroendocrine tumor history, synovial sarcoma tumors, and mucinous colon tumors, you have to be very careful. The reason? They can be very bright on T2. This is a mucinous colon tumor metastasis, and you can see the T2 shine-through effect. So it is not a benign lesion, but it is a metastatic lesion to the liver. How about this one? It is really important to diagnose cholangiocellular carcinoma and not hemangioma, and the clues are, there is always necrosis in these lesions, some form of necrosis, and you never see this kind of central filling in hemangioma at the early phases. Look at this one. So this is a fibrotic tumor. It can collect the contrast on the later phases, and look at the T2 signal. So it doesn't have a high T2 signal. So these are the clues. On a vascular phase, it can mimic a hemangioma, but on T2-weighted images, it is different. And it never goes into the portal vein. So this was a patient with a biliary portal thrombus. How about hepatic adenoma? I won't touch on that, but there are some signs useful, which is called atoll sign. You can see that the enhancement pattern and also T2 signal might be important to diagnose this inflammatory adenoma. And this is, we call in our practice, reverse atoll sign. We see in some forms of inflammatory adenoma. Okay, again, this lesion is very important. Once you know the findings, you can diagnose this lesion because it's a fibrotic lesion. It is a lesion, it can be benign, it can have a malignant behavior. There are focal forms, also diffuse forms, and there are mixed forms. And just remember, biopsy may be inconclusive. So this was one of our patients. You can see T2 moderate to bright, but there's a scar. But look at the enhancement pattern. Peripheral enhancement, homogeneous, kind of filling towards the center, and it blends with the rest of the liver and the later phases. How about this one? This is fairly similar, but this is called diffuse form. You can see T2 signal. These areas are due to fibrosis, and look at the enhancement pattern. So you can see homogeneous enhancement. And I don't have a patient with angiosarcoma, but this is a very nice article which came out in the December 2013 in Abdominal Imaging. They published like 7 patients, and they say that sometimes it might be very difficult to differentiate from benign hemangioma. But we have a patient with splenic angiosarcoma, and you can see the metastatic angiosarcoma lesions in the liver, and they can have peripheral enhancement pattern, kind of a filling towards the center. So you have to be careful if the patient has malignant type of clinical features. Okay, this is also extremely important because all lesions appear dark on ultrasound, either they're hypervascular or hypovascular. I will show you a case with a focal fat sparing and a hypervascular liver metastasis, and I'm going to show you how you can differentiate between two. And it is very important to detect hypervascularity in a fatty lesion. Okay, so this is a hemangioma. It appears dark on ultrasound. If you see such a lesion, the next step should be MR, not CT, because you can better characterize these kind of lesions with MRI. Because look at the CT, you see the peripheral nodular enhancement, but it's so bright on MR. So it is so typical for these kind of hemangiomas in a fatty liver. How about these 2 patients? So we were puzzled with these patients because one had a focal fat sparing, the other one had a hypervascular metastasis. Both patients have a cancer history. So how are you going to put the diagnosis? It is not possible to diagnose from these images, but if you do in-phase imaging, look at the metastasis. It is dark on in-phase, and also, as shown by Dr. Basalama, pseudotumors or focal fat sparing never has restricted diffusion on DWI images. But look at the metastasis. It has restricted diffusion, and they took the lesion out, and we confirmed that it was a metastasis from colon cancer. How about this thing? If you're looking hypervascularity in a fatty lesion, you need to do in-phase imaging. So your TE should be 4.5 millisecond for post-contrast images. This is the fat. So we were puzzled. Is this adenomatosis? Is this multinodular fat? Because there were many lesions like this. And we did in-phase post-contrast imaging. You can see the arterial phase. It is hypervascular. But look at the outer phase. You don't see the lesion. So if you're looking for hypervascularity in a fatty lesion, you need to do in-phase dynamic imaging. Okay, how about this patient? I call this invisible fat on CT. Why? Because if you look at the non-contrast CT, you don't see fat here. But actually, if you do the in and out of phase imaging in this patient, you can see there is some form of signal drop, and the surgeon decided to take this lesion out. We didn't know what it was. We told the surgeon it contains fat, could be adenoma, could be HCC, and actually it turned out to be a epithelioid angiomyolipoma. So it is hypervascular, blends with the liver, it is T2 signal is high, and there's some form of restriction. So this is a lipid-poor angiomyolipoma. But I'm going to show you another case. This time we are sure that there is fat from CT because it is similar to the subcutaneous fat. When you do the MR, right on T1 and T2, look at the enhancement. Peripheral nodular and filling towards the center. But the clue is fat. So if you see a fatty lesion like hemangioma, you can call angiomyolipoma. And you have to be careful in fatty livers because you can have HCC in these patients. Look at this patient with fatty liver, no history of hepatitis, but the patient has typical findings, type 2 diabetes. And this patient is hypervascular lesion, and you can see the washout. So this was an HCC in a fatty liver. So you have to be very careful in lesions within the fatty liver. And look at this one, another interesting one, hyperechogenic rim, CT. You're kind of puzzled. When you do the MR, it is T2 very bright. You see the shine through effect, and there is bright dot sign. So this was, you combine the imaging findings, ultrasound and MR findings, and you can come up with the diagnosis of atypical hemangioma. How about this one? If you see something in your practice like this, you're always puzzled because many lesions are hypervascular and they stay the same on the later phases. And the clue is the signs of portal hypertension, because this is a typical finding in Budd-Chiari syndrome. You can have many hypervascular benign lesions, and they're mostly less than 3 centimeters, and they may grow, and you need to follow up these lesions. Okay, this is a very interesting patient. Does anyone have a diagnosis in this patient? Because this is another typical finding. If you know it, you can diagnose. If you look at the lower phase images, you see the hypervascularity kind of blending with to normal liver, and this is like Caroli-like appearance. So if you have these two findings together, this is very typical. Actually, this patient went to transplantation and we had the diagnosis. It is called Oster-Weber-Rinde syndrome. And the biliary findings are believed to be due to hepatic artery ischemia. Okay, abnormal liver lobe. Look at these two patients, similar. This one is a lobar hemangioma, but this one, these are not hypervascularity, these are calcifications. This was an alveolar hydatid cyst. And look at this one. This one was a fatty liver, which we proved by MRI, but look at the hypervascularity in the right lobe. It is due to the portal vein thrombosis because you have compensatory increased flow to the right lobe from the hepatic artery. Okay, this patient is an hemangioendothelioma, and you can see the lesions very typical. They can have a scar, and they show very typical enhancement pattern. But we were puzzled with the right lobe, you can see here, and we didn't know what it was. But we thought that this could be mixed form of diffuse and focal form of hemangioendothelioma, and the PET findings were also positive in this lesion. And the biopsy was inconclusive. So we went to the pathologist, we told that this could be hemangioendothelioma, and he said, yes, it may be. So in some patients, you need to talk to your pathologist to put the final diagnosis. And this is CT, kind of helps you in such a patient. You see the calcifications within the lesions. Okay, cirrhotic patients, you have to be very careful because hypervascularity is important, but only a quarter of them turn out to be HCC. Most of them are AV shunts. You can see blending with the normal liver and no diffusion restriction. And you have to be careful. Hemangiomas are usually shrink in cirrhotic livers. This was our case. We usually follow these patients. In cancer patients, it is extremely important. Breast cancers, I don't like those patients because they can have many hemangioma-like lesions which are metastatic. But look at this lesion, fairly typical. If you have hypervascular lesions in a neuroblastoma, if you do hepatobiliary phase imaging, you can see uptake of the contrast or isointensity to the liver. These are called benign FNH-like lesions or nodular regenerative hyperplasia due to platinum chemotherapy. And another patient with colon cancer, you can see many lesions in the liver that take up the contrast on the hepatobiliary phase. This turned out to be a similar scenario. And also, sometimes carcinoid and neuroendocrine tumors can be very difficult to differentiate from hemangioma. In those cases, diffusion is helpful because you see restriction within the lesions and you see necrosis. And this is a patient who has vanishing hemangioma. You can see initially in 2009, this was a colon cancer patient, and look what happened at the end. It became a solitary fibrous nodule. Okay, this is one of my last cases. Left renal cell cancer, post-op PET-CT positive patient, just remember only one benign lesion can have PET-CT positivity. It is hepatic adenoma. So how can we differentiate benign from malignant? You look at the enhancement pattern. This is neuroendocrine tumor. This is corona enhancement that can be seen in HCC. And if you see washout, it's very typical for HCC. And this is my last slide. If you have an unidentified hypervascular lesion in your practice, just do hepatobiliary phase imaging with a hepatocyte-specific contrast agent. In a normal patient, if you see these two enhancement patterns, it is typical for FNH. If you see it in a cirrhotic patient, in 9% of the patients, it can be HCC, and in cancer patients, it is most likely a nodular regenerative hyperplasia. And just remember, hemangioma is born, it lives, and it dies. So this is the life cycle. And you can do biopsy-less diagnosis in normal patients, but you have to be careful in cirrhotic patients to do benign diagnosis. And in cancer patients, just remember the nodular regenerative hyperplasia. And I would like to thank you for your attention. This is the word friendship map from Facebook users, and this is my email. If you need the slides, just email me. I can send you the slides. Thank you.